Hello again, my name is Josh Jacob, consultant orthopedic surgeon. This is my colleague Ashwinathan, and today we're going to talk about keyhole surgery of the knee, also known as arthroscopy. Now, keyhole surgery historically has started with surgery involving using a telescope into the bladder, or called cystoscopy. It was a rigid scope, but it has evolved since then, and through the advancement of technology and medicine, keyhole surgery has come a long way, and now we can do a lot of things inside the knee, inside the hip, inside even the wrist or little toe joint. And people,
toe joint?
Yes.
Okay.
And people can do things in such a way that they can get a good panoramic view of the articular status of the knee or the joint. In our case, we are going to look at the knee. This is a knee joint model that he had made the other day.
Thank you.
That's the kneecap, the quadriceps muscle, the patella tendon, and inside that is what we're trying to ascertain. That blue structure there that you see is called the meniscus. They are like the shock absorbers in the knee, and they help to transmit weight and load and also lubricate the knee. We've got two big ligaments, the anterior cruciate and the posterior cruciate. The cruciate ligaments are the ones that are notorious for rupturing during contact sports or non-contact sports, or coming off motorbikes and any other violent form of trauma. Often there isn't any tackle involved, and just the way the knee pivots itself can cause problems. Now, as far as keyhole surgery is concerned, it's generally a day case procedure, and all your surgeon would do is essentially have two little nicks in the knee, the size of your little finger, and put in an instrument that is almost just the size of a biro pen. Through one of the portals, he has a good view of the structures, and through the other portal, which is often called the working portal, he introduces instruments and is able to address the problem.
So before we do that, we'll also have to fill up the knee with fluid, and it is saline fluid.
You mean seawater bucket loads?
No, it's a sterile saline fluid, which allows you to see more inside the knee, and hence the knee would be swollen, though we drain all the fluid out, but still, depending upon the complexity of procedures, sometimes 3-4 liters of fluid will pass through your knee. Hence, it is normal for the knee to be swollen after arthroscopic surgery or a keyhole surgery. Now, Mr. Jacob, what are the procedures you can do through a keyhole surgery?
So depending on what the patient comes with.
Sure.
When we ask the history and examine the patient, classically we're expecting to find problems like a mechanical locking or giving way, where they've torn a bit of cartilage, or even torn the actual main ligament called the anterior cruciate or the posterior cruciate ligament, or taken a bit of gristle from within the knee area called the femoral condyles. Now, depending on where the location of the tear is, we'll do our best to save the meniscus or preserve the cartilage and try and repair it. Now, if that is beyond redemption and salvage, then we'll have to trim it so that the knee is stable once again.
So if you have to take a bit of meniscus away because you can't repair a meniscus, what are the risks of taking? What are the risks of taking the meniscus out? This is an often question that I'm asked by most patients.
I think it's imperative to reiterate what I've just said, that we do our best to preserve the meniscus because they're such a crucial part of the knee. If it's a knee that's been designed by God to give you stability and to give you the best outcome, then we need to keep it there. And if you're trying to remove it, we will have to remove the bare minimum, just enough so that the knee retains stability and doesn't in any way violate or compromise the load-bearing status of the knee, thereby predisposing you to arthritis.
So that's one of the things. So when you take the meniscus out, though we take out the bare minimum, there's a slightly increased chance of arthritis. But having said that, we're taking the meniscus out because you're in pain or because you can't straighten your knee. So it is.
We're just trimming it rather than.
Exactly. We're trimming it. We're not taking it out. Now, the arthroscopic surgery is done for loose bodies. Is there any other reasons why you would do arthroscopic surgeries?
Yeah, of course, to reconstruct the ligament called the anterior cruciate ligament. And routinely, in my practice, what I do is to counsel the patient to get the best out of the procedure if they have to have a procedure. Incidentally, I don't have an anterior cruciate ligament, and I managed to do without that. But remember that
I didn't know that.
Yeah.
Okay.
Without an anterior cruciate ligament, your knee itself can be rendered potentially unstable, and we will have to do our best to keep your knee stable so that you don't scuff your articular cartilage. Plus, if you want to engage in contact sports and get back to fighting fitness, then you'll want your cruciate ligaments all intact. And if you do have to have surgery, there are various ways to do that. We don't have time to go through all of that, but predominantly we would take either your hamstring tendon or your quadricep tendon and use that as the new ligament. So your tendon is actually becoming a ligament, and that will involve a little incision here if I'm taking the hamstring tendon, and through that I can harvest your tendon and prepare it in such a way that using keyhole surgery without any open slashes on the knee, just the two little nicks, we can reconstruct the tendon so that the torn ligament that was gone from here will be reconstructed in such a way that it's attached to your top bone called the thigh bone, attached to your leg bone called the tibia bone, and thereby confers stability. Of course, it involves a lot of physiotherapy after that to get your knee moving and get you conditioned to the new tendon that is now becoming a ligament.